Welcome students, myself Dr. M. Ambika, Associate Professor from Department of Oral Pathology from Vinayaka Mission Sankaracharya Dental College, here to present a topic on oral manifestation of dermatological disease. These are the contents of my presentation. We know that skin is considered the largest organ of the body and has many different functions. Both the protective, sensory, secretory, excretory and water balance functions are common in both skin and oral mucous membrane. So a vesicle is a clear fluid-filled lesion present below the epithelium or between the epithelium and connective tissue, which ruptures to form an ulcer. When the vesicle or a fluid-filled lesion is less than 5 mm, it is known as a vesicle. If it is larger than 5 mm, it is known as a bulla. When there is a break in skin or mucous membrane with loss of surface tissue, followed by disintegration and necrosis of epithelial tissue and often pus, is termed as an ulcer. First we will be seeing about vesiculobullous lesions. Skin is characterized by blistering lesions. So it is categorized histopathologically as intraepithelial and subepithelial. Intraepithelial may be subcorneal, mid-epithelial or suprabasal. You see the picture over here, you can see this is in corneal area and this is in the suprabasilar area. So example can be given as pemphigus. For subepithelial, the vesicle or bulla is present between the epithelium and the connective tissue. So example can be given as pemphigoid, erythema multiforme, epidermolysis bullosa, dermatitis herpetiformis. So few terminologies we can know before entering into the topic. So acanthocytes. What are acanthocytes? Acantho means spike cells. Cytes means cells. So for spike cells, example spur cells like spur cells in RBC can be given. So while tissue processing, the tissue is subjected to various chemical components. So the cells tends to shrink. So if you see here, the cells tends to shrink, but still the attachment is maintained between the cells by means of desmosomes. Hence it gives a spiked appearance. Therefore it is known as acanthocytes, that is spiked cells. And acantholysis means break between the cells or lysis between the cells. And it is also known as loss of cell-to-cell adhesion between the keratinocytes, or intercellular bridges between the keratinocytes is being lost. That is acantholysis. And acanthosis, it means diffuse hypertrophy or increase in layer of prickle cell or spinous cell layer is known as acanthosis. So this is a classification of vesiculobullous lesion which is categorized as hereditary, traumatic, allergic, autoimmune, viral and neoplastic. So these are the following subheadings under the categories. So first we'll be seeing about pemphigus. So pemphigus is a group of autoimmune blistering disease of skin and oral mucous membrane. So in Greek, pemphix means bubble or blister. So it is characterized by vesicles and bulla which develops in a cycle. So histologically it is characterized by intradermal blisters. So etiology is circulating IgG antibodies are directed against keratinocytes. And there are three subtypes of pemphigus: pemphigus vulgaris, pemphigus foliaceus and paraneoplastic pemphigus. So as we know, pemphigus is autoimmune blistering disease affecting skin and oral mucous membrane, which mainly targets, where the autoantibodies mainly targets the desmosomal attachment. So these are the desmosomal attachment. So we know that the cell to cell attachment, it has some junctions. It may be gap junction, tight junctions, adherent junctions, desmosomal junction and hemidesmosomal junction. In oral epithelium, the cell to cell attachment is desmosomal junction, whereas junction between the epithelium and the connective tissue is exhibited by hemidesmosomal junction. So over here the attachment is exhibited by cell adhesion molecules which may be cadherins, that is desmoglein, desmocolins and integrins, selectins or desmoplakins. Here the IgG autoantibodies are directed against desmoglein 1 and 3 which is present in the cadherin superfamily. Okay, when the autoantibodies are directed against these desmoglein 1 and 3, It leads to the activation of complement system, which leads to the release of inflammatory mediators. This leads to the acantholysis. The final product is the acantholytic cells, which are also known as Zang cells. So once acantholysis is being formed, there is a formation of gap between the cells. So this leads to change in the osmosis and leads to influx of fluid between the epithelial junctions or intercellular junctions, which leads to the formation of intraepidermal cavity formation. So under clinical features, you can see painful ulcer or bulla formation, which are filled with thin watery fluid. When they rupture, they leave raw eroded area, and the patients show positivity for Nikolsky sign. What is Nikolsky sign? It is loss of epithelium by rubbing unaffected epithelium or skin, which leads to prevesicular edema formation, which disrupts the intraepithelial junction. Sometimes the junction between the dermal and epidermal junction can also be disrupted. So this is known as Nikolsky sign. A rare variant of pemphigus vulgaris is pemphigus vegetans and is characterized by flaccid bulla formation and also characterized by erosions and pustules, which are known as Newman and Halope. It is characterized by presence of cerebriform tongue, where the tongue has sulci and gyri on dorsum of tongue. So mucous membrane is first affected, followed by skin. In mucous membrane also, it is characterized by ill-defined, irregularly shaped vesicles or bullae, commonly seen in gingiva, buccal mucosa or palate, and the painful erosions or eruptions will be slow to heal. If it involves larynx, it leads to hoarseness of voice. Inability to eat or drink may also be seen in patients. It may also involve other mucous membranes like conjunctiva, esophagus, labia, vagina, urethra, cervix, pharynx and anus. Histologically, we know that it is an example of intraepithelial blister. So the cavity formation will be seen between the epithelium. So acantholysis will be noted and acantholytic cells also will be noted. Suprabasilar split can be noted. This is suprabasilar split, that is above the basal cell layer, where the basal cell projects into the cavity, will give to the appearance of tombstone like appearance. So the vesicle space is filled with clumps of Zang cells, which are also known as degenerative cells, or swelling of nuclei with hyperchromatic staining can be seen. The fluid usually is filled with polymorphonuclear leukocytes and lymphocytes. Immunofluorescent testing can be used, which under direct immunofluorescence shows presence of IgG, C3, IgA and M. So Zang test, it is a cytological test or smear test which is used to identify the Zang cells, or also known as acantholytic cells. So it reveals multiple acantholytic cells which presents itself as large round keratinocytes with hyperchromatic nuclei which are hazy with absent of nucleoli, and addendum cytin basophilic cytoplasm can be noted. So because of the condensed cytoplasm, it gives a mourning effect of the cell, and also perinuclear halo can be noted. So this is the perinuclear halo, this can be noted. So this is a Zang cell which is identified under a Zang smear or test. So the diagnosis which can be used for pemphigus vulgaris is skin biopsy, electron microscopy, where we can see widening of intercellular space followed by splitting of desmosomal junctions, and under direct and indirect immunofluorescence we can see the fishnet appearance or chicken wire pattern can be seen, where the deposition of IgG antibodies, autoantibodies are being directed. Under ELISA, it detects IgG autoantibodies which is directed against desmoglin 1 and 3. Differential diagnosis can be given as pemphigoid, erythema multiforme, bullous lichen planus. So other types of pemphigus are foliaceous, where desmoglin 1 is being targeted. For vegetans, desmoglin 3 is being targeted, and for IgA pemphigus, desmoglin 2 is being targeted, and for paraneoplastic pemphigus, desmoplakin is being targeted. So this is about pemphigus vulgaris. Next, coming to bullous pemphigoid. So it is a common subepithelial blistering disease, chiefly occurs in adults whose age range from greater than 60 years. It is self-limited and lasts for 5 months. It is an autoimmune disease where the autoantibodies are directed against lamina lucida of the basement membrane, that is on the hemidesmosomes. And the antigens, which are nothing but glycoproteins, and are here it is referred as bullous pemphigoid antigen 180 and 230. When the antigen antibody complex is being formed, it leads to the activation of complement system, causing localized damage to the basement membrane, resulting in vesicle formation in the subepithelial region. Under clinical manifestations, we can see it commonly affects skin and seldom affects oral mucosa. If at all oral mucous membrane is being affected, it may be associated with internal malignancies. These lesions usually follow a pattern of vesiculation followed by ulceration and then healing without scar formation, should be noted. So elderly people in the age group of 60 to 80 years are usually affected with no gender predilection, and the skin lesions usually presents itself on trunk and limbs, which undergoes regression, and the skin lesions are comparatively smaller than cicatricial pemphigoid. Oral lesions are smaller and they are slow to progress and are less painful when compared to pemphigus and cicatricial pemphigoid. So it presents itself as desquamative gingivitis, which is a common manifestation seen in bullous pemphigoid. And the gingival lesion is characterized by generalized edema, inflammation and desquamation with localized area of discrete vesicle formation. So a differential diagnosis will be erosive form of lichen planus, pemphigus and other subepithelial bullous dermatosis can be given. Under laboratory investigation, under direct immunofluorescence study, it shows detection of IgG and complement C3 antibodies which are bound in a linear fashion on the basement membrane, that is, it is known as linear band. Whereas under indirect immunofluorescence, if you see, the deposits are mainly seen as a salt split appearance, where the antibodies are mainly bound to the epidermal side. This salt split skin test is particularly useful in distinguishing bullous pemphigoid from pemphigus. Under histopathology, we can see presence of subepithelial vesicle or bullae formation, where it causes separation of full thickness of epithelium from the underlying lamina propria. Acantholysis and epithelial degenerative changes are absent in pemphigoid. Subepithelial connective tissue shows inflammatory cell infiltrates like lymphocytes, macrophages and eosinophils in the perivascular areas can be noted. So this is about bullous pemphigoid. Coming to cicatricial pemphigoid, it is also known as benign mucous membrane pemphigoid. It is a chronic autoimmune subepithelial disease chiefly affecting the mucous membrane, hence the name benign mucous membrane pemphigoid, and it usually affects patients above 50 years of age. It results in mucosal blistering, ulceration with scar formation, whereas in bullous pemphigoid it heals without scar formation. The primary lesion of mucous membrane pemphigoid occurs when the autoantibodies are directed against the protein in the basement zone, chiefly bullous pemphigoid antigen 2 and laminin 5, which are targeted in cicatricial pemphigoid, which causes subepithelial split and vesicle formation. It frequently affects middle-aged or elderly females. The most common site is oral mucous membrane followed by conjunctiva. So disease also involves nose, pharynx, larynx, esophagus and genitalia. Oral manifestation usually presents with vesicles and bulla, commonly involving gingiva, where the gingiva exhibits raw eroded areas, usually bleeds for weeks or months. This is known as chronic desquamative gingivitis, is a common clinical presentation of cicatricial pemphigoid. In severe cases, large vesicle or bulla may develop on palate, buccal mucosa, alveolar mucosa and also tongue also may be involved. Bulla are quite large when compared to bullous pemphigoid and they may persist for several days. The mucosal bullae are often tense because of the full thickness of epithelium covered over it, and pain and bleeding are common complaints in these patients. Nikolsky's sign is positive, which is similar to the pemphigus vulgaris. Here also we can see Nikolsky's sign has been positive. So in eye lesions, we can see conjunctivitis, blister formation, corneal ulceration that may lead to blindness, swelling of fornix and corneal opacity can be noted, fibrosis and scarring of lacrimal ducts can be seen. This may lead to dryness of eye. Scarring may cause adhesion between bulbar and palpebral conjunctiva. So this is a clinical presentation. So adhesion between the bulbar and palpebral conjunctiva is known as symblepharons. It may lead to upper eyelid turns inwards, that is known as entropion, resulting in rubbing of eyelashes against the eye. So this is known as trichiasis. It may lead to severe conjunctivitis where the lower eyelashes are totally removed because of trichiasis. So once all the symptoms resides, it leads to healing stage. Under healing, it heals with scar formation. Scar formation may lead to complete blindness. This is the severe form of cicatricial pemphigoid affecting the eyes. Under histopathology, extracellular edema and vacuolation in basement membrane zone can be seen, which are the earliest histological changes in cicatricial pemphigoid. Gradually there is subepithelial vesicle or bullae formation, and subepithelial split can be noted over here like this. Acantholysis and epithelial degenerative changes are absent, and polymorphonuclear neutrophils may be found within the vesicular fluid. Blood vessels are often dilated and prominent in the superficial part of the lamina propria. So this is about cicatricial pemphigoid. Coming to erythema multiforme. It is an acute inflammatory dermatological disorder, frequently involves skin, mucous membrane and sometimes internal organs. It is characterized by the presence of iris or target lesions. So there are two forms of erythema multiforme, that is erythema multiforme minor and erythema multiforme major. Minor is where localized eruption with no or mild mucosal involvement can be seen. In major, mucosal erosions of raised atypical target lesions are present. There is one form of erythema multiforme which is considered to be the severe form, which is known as Stevens-Johnson syndrome. It is characterized by mucosal erosions with widespread distribution of flat atypical targets or purpuric macules can be seen. The etiology may be due to infections of bacterial and viral infections like tuberculosis, herpes simplex, infectious mononucleosis, histoplasmosis. It may be due to drug hypersensitivity like barbiturates, sulfonamides, salicylates, oral pills, etc. And also due to hyperimmune reactions or other miscellaneous factors like radiation therapy, Crohn's disease and vaccinations. So clinically we can appreciate the lesions commonly in males in the age group of 15 and 40 years. The lesions usually develop rapidly like erythematous macules, papules, vesicles or bullae, which symmetrically distributed over hands, arms, legs, feet, face and neck. The classic dermal lesion is target iris or bullae based on the appearance. The dermal lesion consists of concentric erythematous rings separated by rings of near normal color. So this is the erythematous rings. These erythematous rings are separated by near normal color of the skin. The mucosal lesions of the disease also consist of macules, papules or vesicles, mostly involving tongue, palate, buccal mucosa and gingiva. Oral manifestation, the oral lesions are mainly involve tongue, palate, buccal mucosa and gingiva, which presents itself as hyperemic macules and papules, which are very painful and usually leads to discomfort to the patient, and they bleed profusely. Sometimes it may leads ulcerated lesions because of profuse bleeding leads to hemorrhagic crust formation over the lips. Because of the hemorrhagic crusting, it may lead to foul smell in the mouth and difficulty in eating and swallowing. Tracheobronchial ulcerations and pneumonia may also be noted. It is uncommon in children and older individuals. If it is noted in older individuals, there is increased possibility of internal carcinoma. Steven-Johnson syndrome, a severe form of erythema multiforme. It commences with prodromal symptoms like fever, malaise, photophobia, and followed by eruptions of oral mucous membrane and genital and skin areas. Patient usually recovers unless they involved with any secondary infections. The oral lesions are very severe and painful, making mastication impossible. Mucosal lesions or bulla are usually covered with thick white or yellow exudates, and hemorrhagic crust over lips may be noted, and erosions of pharynx are also common. All these manifestations gives a similar picture to ANUG, that is acute necrotizing ulcerative gingivitis. So the eye lesions are mainly comprised of photophobia, conjunctivitis, panophthalmitis, keratoconjunctivitis sicca. And the genital lesions include non-specific urethritis, balanitis, vaginitis, or vaginal ulcers can also be noted. Others like tracheobronchial ulcerations and pneumonia can be noted in these patients. Histopathologically, the lesion shows intercellular and intracellular edema of the epithelium with focal microvesicle formation, and the edema results in pooling of eosinophilic coagulum within the epithelium. Diffuse infiltration of acute and chronic inflammatory cells can be seen in the underlying connective tissue with vasodilatation of blood vessels, and subepithelial cleft is seen in this erythema multiforme. Epidermolysis bullosa. So epidermolysis bullosa is a group of inherited bullous disorder characterized by blister formation, which occurs in response to mechanical trauma. The underlying etiology may be mainly due to mutation of genes. It is classified into three types. Epidermolysis bullosa simplex, which is due to keratinin gene mutation, and junctional epidermolysis bullosa, which is due to laminin gene mutation, and dystrophic epidermolysis bullosa, which is due to type 7 collagen. So clinically we can see blistering of skin, tooth decay, deformed or lack of finger or toenails, internal blistering in throat, stomach and intestine can be noted. Scalp blistering with loss of hair can also be noted in these patients. Excessive sweating, hardness of skin on feet or hand can be noted, and the symptoms may vary from different types. So oral manifestation is very important in this epidermolysis bullosa. It shows both soft tissue and hard tissue manifestation. Soft tissue we can see increased fragility. Perioral lesions can be noted, microstomia, ulcerations, ankylosing, obliteration of oral vestibules can be seen. Dental manifestation like junctional epidermolysis have severe enamel hypoplasia, risk of increased dental caries can be seen, and severe dental crowding and deep bite can be noted in these patients. So histopathological features show separation of epidermis from dermis with subepithelial cleft formation, and there is absence of significant inflammatory response, and adjacent epidermis is usually normal. So this is about epidermolysis bullosa. Coming to oral lichen planus. Oral lichen planus is derived from the Greek word where lichen means tree moss and planus in Latin means flat. So lichens are primitive plants composed of symbiotic algae and fungi. So it literally suggests flat fungal infection, which is a misnomer, where clinically the appearance may mimic a flat fungal condition, but it is a immunologically mediated mucocutaneous disorder, and the predisposing factors may be due to genetic background or autoimmunity, immunodeficiency, drugs, dental material, stress and habits. So the etiopathogenesis for oral lichen planus is purely T cell mediated inflammatory lesion, and the trigger for keratinocytes apoptosis is usually unknown. The lymphocyte infiltrate in oral lichen planus is composed of exclusively T cells, and how these activated T cells like CD8 killer T cells are targeted against a keratinocyte which leads to its apoptosis is unknown, but a postulated hypothesis is that degenerated mast cells which leads to the release of tumor necrosis factor alpha leads to activation of T cells, which leads to activation of matrix metalloprotein 9, which in turn leads to break in basement membrane. So this leads to T cell migration from microvasculature to lamina propria and then enters the epithelium, which leads to apoptosis of the keratinocytes. And the activated T cells may also lead to release of Rantes enzyme, which leads to activation of mast cells, which in turn leads to release of tumor necrosis factor alpha, and the cycle continues. So this is the etiopathogenesis of oral lichen planus. So the main cell involved is cytotoxic T cells. Clinically, it mainly involves middle-aged females, and the classic skin lesions for oral lichen planus can be described as 6 Ps, that is pruritic, polygonal, planar, purple, papule and plaque. Pruritic means itching, polygonal is means of any shape, planar means it mostly flat, purple in color, it may be exhibit as papules or plaques. The lesion may appear as lazy white raised patches of tissue and red swollen tender patches of tissue, and sometimes as open sores. So the location may be commonly buccal mucosa, gingiva, tongue, inner tissues of the lips, throat, esophagus. So the red inflamed lesions and open sores may cause burning sensation or pain occasionally. So the other signs or symptoms may include metallic taste sensation or blunted taste sensation if the tongue is affected. Dry mouth can be seen, difficult in swallowing if the throat or esophagus is affected. Sensitivity to hot or spicy foods can be noted. Bleeding and irritation with toothbrushing can be noted. Skin lesion usually appear as purplish flat top bumps that are often itchy. Nails you can appreciate in finger or toenails, which may result in ridges on the nails. Thinning or splitting of the nails can be noted, which may lead to temporary or permanent nail loss. So the characteristic oral finding of oral lichen planus is presence of Wickham striae, that is the fine white lines. It may be grayish white also, or dots seen on the pruritic papular rash on the buccal mucosa. So macroscopic appearance of this appearance is mainly due to histological phenomenon hypergranulosis in the selected area. So it is named after Louis Frederick Wickham. Okay, so Wickham striae is nothing but fine white lines which are seen in the buccal mucosa, and it is mainly due to hypergranulosis histopathologically. Clinically, it has 6 subtypes. The first is reticular pattern. The reticular pattern is considered as a classic form of lichen planus. This form occurs most frequently, and it is white lazy lines called Wickham striae can be noted commonly. The tissue is somewhat raised, and the patient may report that the areas in contact with the tongue feel rough in texture, like this. Presence of Wickham striae and radiating white striae can also be noted in the buccal mucosa. This is reticular pattern. And the plaque form is represented by thick plaques of varying sizes that may be smooth and somewhat lighter in color than the surrounding tissue. So sometimes it may be confused with leukoplakia. The tongue is particularly the common area to be involved with a plaque form of oral lichen planus, and they often appear bald, like represented here, with denuded papilla, and it has higher association with malignant transformation, the plaque form. Followed by the papular pattern. The papular pattern is noted by small pinpoint papules appearing as small white dots measuring approximately 0.5 mm in size. The bullous form consists of vesicles from a few millimeters in diameter to much large vesicle formation. Eating and speaking will be difficult for these patients. This form is seen most often on the buccal mucosa, followed by tongue. Followed by the atrophic form of oral lichen planus. It consists of red erythematous area and may include reticular or plaque-like surfaces, and the red margins affected by lichen planus and the plaque-like areas superior to the marginal areas in this picture can be appreciated. The next is the ulcerative form. It is the erosive type of lichen planus with loss of surface epithelium in the buccal mucosa. So here you can notice the erosive area of lichen planus in the soft palate can be noted. A mixture of erosive and reticular lichen planus with some candida albicans can be seen in this picture affecting tongue and buccal mucosa can be noted. So this is the ulcerative form of oral lichen planus. There is an entity known as lichenoid reaction. The most common material used in dentistry is known as amalgam, not only because of amalgam, maybe due to other flavoring agents present in food or drugs may also lead to this lichenoid reaction. Okay, although most commonly affected by dental materials, the lesion is usually isolated, affecting only one side of the buccal mucosa, whereas lichen planus affects both sides or involves both sides of the buccal mucosa. Whereas in lichenoid reaction, once the allergen has been removed, the lesion subsides. Histopathologically, the epithelium is hyperkeratotic with irregular acanthosis and focal thickening in the granular layer. Wedge-shaped hypergranulosis can be noted. We saw in the previous picture. The lymphocytes are intimately associated with basal keratinocytes, which shows degeneration, necrosis, and resemblance in size and contour to more mature cells of stratum spinosum. This is known as squamatization. As a consequence to this destructive infiltration results in redefining of normal smoothly undulating configuration of dermo-epidermal junction to more angulated zigzag contour, which is represented as sawtooth appearance of retiridges. And the inflammatory cell infiltrates usually arranged in a dense band. So you can appreciate here the dense band of inflammatory cell infiltrate, which is a characteristic feature of oral lichen planus, and you can see selective hypergranulosis area, which wedge-shaped areas in between can be noted. Apart from that, civate bodies, which are known as anucleate necrotic basal cells, become incorporated into inflamed papillary dermis can also be seen. It is also known as colloid bodies. These are characteristic of lichen planus but can be found in any chronic dermatitis where basal keratinocytes are involved. So these are the colloid bodies which are appreciated in the basal area of the epithelium. In addition to apoptotic keratinocytes, colloid bodies are composed of globular deposition of IgM or IgA and complements. So there is basal keratinocytes where and all it weakens, the epithelial interface is being also weakened and leads to histologic cleft-like spaces over here. These are known as Max Joseph's clefts. So this is about oral lichen planus. So next is Ehlers-Danlos syndrome. It is an inherited connective tissue disorder where there is abnormal collagen production and it commonly affects skin, joint and blood vessels. It has more than 7 categories of disease, and the classic type, there is defect in type 1 collagen which causes hyperelasticity of skin and cutaneous fragility is commonly seen in this classic type. An unusual healing response occurs in this Ehlers-Danlos syndrome, which resembles crumpled cigarette paper appearance. This is known as papyraceous scarring. Hypermobility of joints and easy bruisability are noted in this case. So we can see the hyperelasticity of skin and joints, especially the common mouth opening is 3-finger breadth, and you can see more than 3-finger breadth is being noted in these patients. And oral manifestation is common in type 8 where marked periodontal activity is noted at an early age. And the classical sign is the patient can touch the tip of the nose with tongue. It is known as Gorlin's sign. And oral mucosal fragility and easy bruisability can be noted in oral mucous membrane also. And gingival hyperplasia and fibrous nodules can be seen. Recurrent subluxation of temporomandibular joint, malformed teeth, stunted root, large pulp stones and hypoplastic enamel can be noted. If you see here, multiple pulp stones can be seen in each quadrants. So this is about Ehlers-Danlos syndrome. Followed by psoriasis. Psoriasis is a common chronic skin disease characterized by increased proliferative activity of keratinocytes, and it mostly presents itself in second or third decade of life. It improves in summer and worse in winter. Symmetrically distributed in scalp, elbow and knee. It is characterized by well demarcated erythematous plaque with silvery scale. These are the silvery scale appearance on its surface resembling thin layer of mica. On removal of this silvery scale, you can appreciate small tiny bleeding spots. These are known as Auspitz sign. In skin it will be red and dusky. So this is the clinical presentation of psoriasis. So histopathologically it is characterized by presence of parakeratin, abundant parakeratin production with elongated epithelial retiridges. In connective tissue there is dilated capillaries, perivascular chronic inflammatory cells can be noted, and there is collection of neutrophils seen in this parakeratin layer. These are known as Monroe's abscess. So this is about psoriasis. Next, coming to systemic sclerosis, also known as scleroderma. It is a immunologically mediated skin lesion which is characterized by abnormal interaction of vascular tissue, connective tissue and immune cells. And it is characterized by dense deposition of collagen in tissues in extraordinary amount. So it is commonly seen in females. The first sign is Raynaud's phenomena. It is mainly a vasoconstrictive event triggered by distress or cold. So where initially the finger becomes white due to lack of blood flow, when the vessels dilate to keep blood vessels in tissue, it turns blue in color, and finally it retains its redness as blood flow returns. So this is Raynaud phenomenon. So white, blue and red due to vasoconstrictive events can be noted. This is known as acro-osteolysis because of the resorption of terminal phalanges. Subcutaneous collagen deposition in face leads to mask-like face appearance, and in nose it leads to ala atrophy which gives mouse phases. Rapid involvement of skin of trunk and proximal limb can be noted. Organ failure, pulmonary fibrosis, heart failure finally leads to death of the patient. So oral manifestation, we can appreciate microstomia, limited mouth opening and characteristic furrow radiated from the mouth, that is like this, radiating from the mouth. This is known as purse string appearance. You can appreciate the reduced mouth opening, blanching of the skin. Okay, all these features clinically resembles oral submucous fibrosis, and also you can appreciate loss of attached gingiva, dysphagia, hypomobile tongue, xerostomia can be noted. Radiographically we can see widening of periodontal ligament space present throughout the dentition, and resorption occurs in varying degree. See, resorption in varying degrees can be noted, and uniform widening of the PDL space can be appreciated in the entire dentition. Localized scleroderma or morphia affects solitary patch of skin, looks like scar, hence the name Encouped saber, that is strike of the sword. Histopathologically, we can appreciate diffuse deposition of collagen which replaces and destroys the normal tissue can be appreciated. So this is about scleroderma. Thank you for watching my presentation, student. Thank you.